Hey there.
Hello.
Hello. Hey, Dr. Buhold.
Yeah.
Yep.
Also,
Oh,
Jonathan from here on
oh,
out.
thank thank you. Hey, Jonathan, could we by chance get the AUD slides that we had for last week?
The cannabis or AUD?
No, the AUD is the one I was looking for. I was looking for something to reference out of there the other day.
Of
Uh,
course. Yeah, yeah,
and
yeah.
they're
Can
both would be,
you can
by
you
the way.
forward me the AUD slides? Yeah. Yeah. And then what else?
Oh, no, that was all.
Oh,
You could
okay,
all
cool.
forward the cannabis ones too if you have them.
Oh, absolutely. Yes.
Thank you.
I'll do both of those.
Oh my gosh. Hi, Lisa.
Hey Taylor, how are you?
Good. It's so good to see you on here. Wow.
I know, such a small world.
I know. What? We should catch up sometime.
Yes, I would love that.
So, as some of you, I'm sure recognize, our group is metastasized, which is wonderful. So, maybe we could start with some introductions from our addiction medicine colleagues from Swedish. Jim, do you want to go ahead and get started and kind of tell about yourself and how you all fit into the group?
Sure. My name is Jim Walsh. I'm the program director for the Addiction Medicine Fellowship at Swedish Medical Center. I'm a family medicine doctor, and we kind of grew out of family medicine, so it's kind of our origin story. We have a program at Swedish Ballard for pregnant moms with substance use problems. It's kind of like a rehab, just happens to be in the hospital because they're pregnant. And we've expanded from there. And we do a lot of perinatal recovery stuff for people delivering babies at first as well as kind of the usual things, hospital consults, outpatient clinic. And we've had a fellowship for a really, really long time, not quite as long as addiction psychiatry, but not so much less. And
No.
we've kind of
When
come up
was
through
your
the process.
start? When did you start it, Jim?
2002.
Right. So only 3 years after. Yeah.
There you go. There you go. There you go. So we've kind of grown as the thing has grown, and we are so excited to do our didactic learning together with you all. That's super fun because there's not enough in any one program. However, because we deeply love vacations, we start a month after you guys. So our fellows get a month off after residency. And I know that wasn't that easy to do in some other institutions. So we're running a month behind. Conversely, you will finish a month earlier than us. So there's that. So
There you go.
let me give our three fellows a chance to introduce themselves as well. Sarah, you want to go first, just because I saw your face first?
Sure. Hey, everyone. My name is Sarah. I use she, her pronouns. I'm one of the new Swedish fellows, and I just finished my family med residency at Swedish, so it didn't go far.
I can go next. My name's Leah. I also use she, her pronouns, also new fellow at Swedish. I also trained in family medicine in Northern California in Santa Rosa. And I'm from Seattle, so excited to be back here for a fellowship.
Awesome. Shivani?
Hi, I'm Shivani. I finished my residency in internal medicine in Omaha, Nebraska, and I just moved to Seattle and I'm loving it here. I'm trying to change resident to fellow, but I'll figure it out eventually. But I use she, her pronouns. Nice to meet you
Great.
all.
And maybe we can popcorn around for the folks in the UW Addiction Medicine and Addiction Psychiatry program. So just for sort of introductory purposes, this didactic series, over the summer, we do this sort of focus on the major substances of abuse and kind of get people on the same page. A lot of medical information, because all of the folks on this will be physicians. But then the didactics kind of morph into what we call our CSATE seminar, which is a Center of Excellence in Substance Abuse Treatment and Education. And it'll still be the same players, but we'll add on fellows in our programming that are social work, psychology, chaplains, and then also medicine folks from down in Pierce County. And so we have programming that's set up for to run through December, and it'll occur at the same time, Thursdays from 2 to 4. But then after that occurs, and the curriculum is really designed to kind of be comprehensive and not just information about medications and medical treatments, but also psychosocial interventions, ethical situations regarding substance use, etiologic models, genetics, um, uh, social determinants of health, really kind of a comprehensive look. And then the second portion of the year, we really kind of allow fellows to help us drive some of the didactics in terms of having fellows present to one another. Swedish folks, talking to us about pregnant people, our psychiatry folks, discussing co-occurring disorders, our medicine folks talking about complex medical conditions, cardiovascular, liver disease, things like that. But this is, a space for us to really learn together. And so why don't I have the fellows who haven't yet introduce themselves and tell where they fit in, which program, and we'll start with Ramita.
Hello, I am Dr. Ramita Goel. I am Addiction Psych Fellow at University of Washington.
Wonderful. Bill, you want to go next?
You bet, everybody. Hey, my name is Bill Trebelcock. I use he, him pronouns. I did residency at Yale in internal medicine, and I'm joining back here. I was in Seattle prior for medical school, so really glad to be back and enjoy joining the addiction medicine team.
Wonderful. Mike.
Hey, what's up, everyone? I'm Mike Silva. I'm in a UW Addiction Psych Fellow. Use he, him pronouns, él en español. Yeah, I also graduated from the UW Psychiatry Residency Program.
Wonderful. Let's see. Leah, did you go already?
Yeah,
Leah,
I
you
am
did
one of
go. Oh,
the
yeah, there you go.
folks.
I got you screwed up with Lena.
I think we're
I
getting
meant to
names.
say Lena. Sorry. Lena, you go next.
Hey everyone, I'm Lena. I'm originally from Wisconsin, but spent the last few years here in Seattle doing my residency at UW in internal medicine, one of the addiction medicine fellows, and I use she, her pronouns.
Awesome. Thank you. Laura.
Hello. Yeah, I'm Laura. I'm an addiction medicine fellow. I use she, her, and I grew up in Virginia, but I just finished residency at UCSF, so just moved from San Francisco.
Very good. And last but certainly not least, Taylor.
Hey there, I'm Taylor Bozich, she, her pronouns. I grew up in Western Washington, and then I did med school at University of Washington, mostly in Spokane, where I was with Elena Dodge, and then did residency at UCSF with Laura, and I'm back here for addiction medicine fellowship at UW. Really excited to be here.
Awesome, very good. So as you can see, this is a really cool group of interdisciplinary fellows, and the idea here is really to have some cross pollination and expertise and treatment. Everyone's sort of rowing in the same direction, maybe from different backgrounds, but kind of all taking care of patients who use drugs, and so. Today, we are going to sort of midway through, going to talk about some clinical cases in regard to some of the things that we have reviewed. For the new fellows joining from Swedish, I will have the recordings from our first 4 weeks posted onto YouTube, and I'll do that after today so that you can look back at the videos. The other thing is that uh, all of the materials that are sort of supplementary materials, I'll make sure that you have available to you. Jim, do you know? Did you get the emails up to this week with all of the lecture stuff, or no? No, okay. So I'll forward that to you, and then we'll make sure that all of the fellows are added to the invites as well. So when I if you could actually, for all the Swedish fellows, if you could put your email address in the chat, I'll add you all to the list and make sure that we get you all going.
Sorry, I didn't want to interrupt, but I just wanted to introduce myself real quick too.
I'm so sorry, Elena.
You're totally fine. I'm one of the new addiction medicine fellows at Multicare, the Good Sam program in Puyallup.
Wonderful, great, thank you so much. So great to have you in the South End, and wonderful to have you in the group. All right. It was funny because you two sort of recognized each other and talked, and so I was like, "Oh, you've already." Sorry.
It's all good.
Okay, so we're going to go through some clinical cases, and this actually is going to be hopefully as interactive as possible. We're going to review sort of the highlights of what we've talked about in terms of opioid management, alcohol management, and then cannabis today. And then next week, you'll have lecture from Amy Kennedy regarding substance use or stimulant use. And then after that, it'll be tobacco with Mark Duncan. And then we will begin the CSATE portion of that beginning in September. So the last week of August, you'll have off. All right. So you'll see my slides. Cool. Okay. All right. First patient. Patient with PTSD presenting to the VA intoxicated on alcohol with concurrent suicidal ideation. So in general, when with evaluating withdrawal, what are the most important elements of the history and current exam, which will guide your current treatment? And I know that's a big question, but really just think of yourself in the emergency room with the patient. What are the things that we need to screen and want to know about when it comes to triage, initial management and care? How do we do that evaluation? And then we'll go into our treatments. I'll let people just unmute themselves and talk. I hate calling on people because I don't want to call people out.
I guess just in terms of acutely triaging, like trying to get a sense of history of withdrawal, and so knowing if they've had a history of seizure, DT, et cetera, if they've been admitted to ICUs before, for withdrawal, helps know kind of like what direction things might go, and then last drink so that you know like where in the withdrawal timeline you are.
Yeah, so incredibly important to know history because that is the best thing that we really have, right? In terms of prediction of future withdrawal. If somebody has had complex alcohol withdrawal in the past, which means delirium associated with alcohol withdrawal, uh, seizures associated with alcohol withdrawal, um, severe alcohol withdrawal, which requires hospital level care and ICU management, alcoholic hallucinosis. Um, that's great. Um, and then last drink is really helpful in cases to get a trajectory. There are cases where patients will have withdrawal symptoms even with high blood alcohol levels, and those are in particular high risk patients. And so if you see somebody who remains with a blood alcohol of above 100, and is already scoring elevated on the CWA scale, which is the standardized measure that we use for alcohol withdrawal in determining severity, either mild below 8, moderate above 8, and below 20 or above 20 to help guide your treatment. Um, we didn't talk a whole lot about different modalities to evaluate alcohol withdrawal. Has anybody ever seen other scoring guides aside from CWA in regard to assessing alcohol withdrawal? What about if a person is delirious in the ICU and can't really talk to you or answer questions well?
Use minds, I think, at Yale.
Yeah,
I assume that's
yeah. Yeah, so there's two different ones that have evidence, pretty good evidence. Mines is one, and then RAS is the other. And so these are scoring guides that don't actually require subjective information. Things like, how much anxiety are you experiencing? Are you having hallucinations, visual or tactile? And I think that they're gaining a little bit more momentum in some hospital systems. We still use CWA here. Harborview is still using that, as is UW. But in ICU settings in particular, you may see MINDS and RASS. Okay. What else from a current examination standpoint helps you triage and determine what the next treatment of choice is? So we already talked about history gathering and then CWA.
If they have cirrhosis, like decompensated liver failure, sometimes that could be contraindicated for certain withdrawal medications.
Great. I love that. So the broad category of other medical problems, right? So, what happens often is you'll see these patients come into emergency settings and they'll experience alcohol withdrawal, but they're coming in for something other than that. They've got a bad infection, they've got delirium associated with encephalopathy because of decompensated cirrhosis. So, any other significant medical condition, ketoacidosis related to diabetes, um, puts people at higher risk for complex withdrawal syndromes. And then when you're determining best course of treatment for a patient, um, liver disease is something that can be useful in sort of keeping in mind about how they may tolerate the medications that you end up choosing. And certainly when patients can tolerate being on Ativan instead of longer acting benzos, that would be the treatment of choice if they had cirrhosis, for instance. Although you may see somebody who's really complicated and has a history of DTs and really still should be on a longer acting agent like phenobarbital or diazepam or Librium. And so you just have to be aware that it may take longer for them to process those medications. It may contribute to encephalopathy or delirium. But from a sort of triage ABC standpoint, we still need to medicate them appropriately. So great. What other things uh, uh, can you think of?
I think for me, looking at, just getting like looking specifically like at their vitals, looking for shakiness, looking if they're like looking around at the room and like seeing things that may not be there, sweating, some of these other objective things. And then like specifically for him, he's got concurrent SI. So maybe doing like a broader, like what exactly are you ingesting to make sure that there's not another like ingestion or something that you need to be worrying about.
Yeah, absolutely. So CWA doesn't actually take into account vital signs, right? And so it's really helpful, I think, to pair objective information like vitals in situations when patients are experiencing um, uh, neurologic deficits because of alcohol-associated problems. Doing a focused neuro exam is really useful, just making sure they're not actually delirious. um, yeah, what other sort of medical conditions go along with alcohol that you see fairly frequently in patients who might be experiencing withdrawal?
Like Wernicke's, and there are high chances of Wernicke's and NCAF. So eye examination for nystagmus or diplopia can be checked.
Perfect. So using King criteria to figure out whether or not they meet criteria for Wernicke's, very under diagnosed still and undertreated, incredibly easy medication to give thiamine and with no side effects, basically, aside from needing to put in an IV. You can actually do IM versions as well, but that's great. And then how do you sort of triage patients in terms of medicine versus ICU level care? What kinds of things sort of guide you one direction or another? This is a little bit of a trick question.
Sort of clinical judgment, right? Like, what's their history? What putting in the whole picture together? What are their CRO scores looking like? How well are they doing after getting medication already?
Yeah, I like that. The response to initial medication, right? So if somebody has an initial CWA score that's elevated and you give, 2 of lorazepam right away and they respond really well, very different than somebody who it just doesn't even touch, right? Um, and the other part is knowing your hospital system, right? Because it's so there you go, logistically, which unit can take the patient, right? And I think that is something that's so interesting actually, having worked on some national protocols for alcohol withdrawal amongst VAs. you know we had this sort of mandate from the federal government to make this great algorithm that's going to be universal for all VAs. And what basically we came up with is, this group of folks who have like looked into all the literature and studied all of the best practices. And the truth was, you really had to go based on a local champion of the hospital that knew what they were capable of doing. Um, because being in a rural hospital setting, where there's different levels of care than you might find at Harborview or Swedish or the VA here, really determines things. There are some hospital systems that don't do phenobarbital on medical floors, and so if a patient needs phenobarbital, they need to go to the ICU by definition of whatever hospital protocol that exists. So knowing your hospital system is super important too. Um, what other kinds of things sort of point you in the direction of ICU over medicine floor? Like when you really think about like the difference from a medical floor to an ICU setting, like what does an ICU kind of provide that a medical floor might not, and or what access points are benefited by ICU level care that medicine floors might not have?
I mean, yeah, you can do like oximetry and monitoring, monitoring of vitals. I mean, you can intubate if you need to use propofol.
Yeah.
You have several different layers of things, I suppose.
Yeah. So, if somebody needs to be on telemetry, for instance, some medical floor is totally fine, absolutely able to monitor them. But if somebody is agitated, right, their vital signs are really unstable. Um, and they may need not just phenobarbital, but some other agent, right? They may need Precedex or Propofol or some other thing that puts them at higher risk for intubation. ICU level care is really kind of the thing that you should do. But really going back to the basic principle is knowing your hospital system. Every hospital system will have some sort of algorithm for like this person needs to go here, this person needs to go there. But those are kind of the general principles that I think of. Okay. Um, and then lastly, as you said, Bill, when somebody does have suicidal ideation, actually recognizing that an acute withdrawal state sometimes actually can be a higher risk period of time for somebody who has suicidality. They may not be thinking clearly and may be more impulsive, so they may need more monitoring than others. All right. So he has a known history of alcohol withdrawal. He reports feeling terrible when he has tried stopping. He drinks somewhere around a fifth and has done so for more than a year. He hallucinates spiders on the walls when he is withdrawing and often gets nauseated and vomits repeatedly in the morning if he does not drink. His last drink was 6 hours ago. Those are his vital signs, which you can read. He appears anxious. He had an emesis episode. His COI was 22 with a BAL of 140. And then he's got macrocytic anemia, a little bit of acute kidney injury, and then some increased liver enzymes, but no stigmata of cirrhosis because he's got normal synthetic function. So his initial withdrawal goes well with supportive care on medicine service combined with scheduled Librium, diazepam, whatever you want to say. And that was initially loaded. And then there were as needed medications for breakthrough elevations in CWA. Day 3 of hospitalization, his CWA scores are low and he's eating and drinking well. He's transferred to our unit because he had ongoing suicidal ideation, and his goals were get treatment for PTSD and alcohol use disorder. Appears highly motivated. So, from this sort of story, everybody know what I mean by loading a patient with medication. What does that mean?
I mean, for me, it usually means like, oh, go ahead, whoever started talking.
I was just going to say, I think of it as giving like an early high dose of a medication instead of doing like a symptom triggered protocol where you're trying to get ahead of their withdrawal symptoms and then have the additional PRN.
Exactly. And so when it comes to the idea of pre-medicating or giving a large dose of a medication, what we're really talking about is evidence for 3 different medications, right? So what are the medicines that have evidence for helping a patient who has a history of complex alcohol withdrawal, meaning DTs, seizures, alcoholic hallucinosis, or very severe alcohol withdrawal? That can reduce the chances of a patient who's appearing in the emergency setting from progressing to a complex alcohol withdrawal. And there are several that are used, but 3 that actually have data that kind of support their use.
I think chlordiazepoxide, lorazepam, and diazepam.
So diazepam, chlordiazepoxide, lorazepam, interestingly, from a preloading standpoint or a large dose up front or scheduled dose over the first 24 hours, either one actually can be done, by the way. Um, lorazepam is not actually a medicine that has evidence for prevention of advancement onto complex withdrawal. We give it as a routine medication as needed, and sometimes you'll even see people use it in a scheduled fashion, but it doesn't have evidence for that prevention. So diazepam definitely. What else? There's one left.
Phenobarbital.
There you go, phenobarbital. So phenobarbital, because of its impacts on not just the GABA system, so phenobarbital stimulates GABA receptors, but it also downregulates glutamate, and so it can have that dual effect of stabilizing the autonomic nervous system by stimulating GABA and downregulating glutamate. Um, when you do phenobarbital or give someone phenobarbital, often you'll see that that dose should be a weight-based dose, and then from there, as needed doses of phenobarbital can be given for breakthrough CWA elevations. Has anybody ever sort of seen phenobarbital tapers, or has anybody seen scheduled benzodiazepine tapers with Librium or diazepam? Some hospital systems and/or training facilities freaking love that.
Swedish basically only uses phenobarb at this point.
And when you do phenobarbital, though, are you doing tapers?
I guess I think of it as so long acting that it sort of self-tapers, and people have the loading dose and can get a few PRNs and then usually don't need more.
Yeah, so there's no evidence actually that doing tapers is beneficial over doing a good load, right? Weight-based load, um, plus accurate follow-up CWA scores with as needed phenobarbital. With that said, again, this is a very interesting caveat to a subject matter that is um, really well documented, but doesn't have great consistency across medical systems. And you'll see phenobarbital tapers all the time. You'll see Librium tapers all the time. The only real difference in terms of evidence is that if somebody does get a taper of one of these long-acting medications, is that they stay in the hospital longer and they get more of the medication, not any sort of benefit. And with that said, if you have an attending that tells you to do a phenobarbital taper or a Librium taper, ask questions and like see where that comes from. Because I will also say, although there isn't evidence, I have patients who are admitted who have been on tapers in the past and very much want to do a taper, and I'm fine with it. Jim, please.
Yeah, there's a little bit built into the CWIS score, at least, that makes assumptions about the patient, that they can talk, that everyone speaks the same language, that they don't have a lot of other concurrent things that are aggravating things, and that basically they're not like super trying to get the medicine too hard. So I do find there's cases where the nursing interaction around trying to figure it out is just too stressful and miserable for everybody concerned, particularly for the nurse, but often can escalate the patient as well if they're sort of trying to get more. Sometimes changing to a slower onset medicine like Librium will fix that problem because Librium is less reinforcing than a faster onset medicine. But there's occasionally when we have to kind of jump ship just because the emotions around it are sort of too much. But I agree with you 100%, Jonathan. It adds at least like 3 days to the whole process. So it is a shame.
But I that's a really good point though, Jim. And I think that it's important to recognize that, there are situations where there's a mismatch in terms of our objective opinion of where they're at in a withdrawal syndrome and their subjective experience of it. Um, and historically, we sort of think of people who are sort of benzo seeking, and it's actually not very common that you'll see people do that, but more commonly, just like you said, just a mismatch. And in those cases, it does. I think it's a good clinical caveat to where tapers might actually be useful. Taking that intermittent potential reinforcement away and just scheduling a medication. When we have folks who have really difficult emotional dysregulation, particularly those patients, borderline personality disorder, et cetera, who have a very difficult time with the anxiety associated with, am I going to get a medication? And so I know I'm getting screened right now and I want to make sure that I get the medicine. It can just be, it can be problematic. So any questions about the just sort of general gestalt of that before we go on to the medications for alcohol? All right. So this is a patient who now is in a better space, not experiencing acute alcohol withdrawal at the moment, but has PTSD as well. What are the 3 FDA-approved medications for relapse prevention from alcohol?
Naltrexone.
Yep, naltrexone. So naltrexone has very good data. What else?
Acamprosate.
Acamprosate, very good.
Disulfiram.
Yep, that's right. So those are the 3 medicines that have FDA approval. And how do you really distinguish between those? What are the patient populations that you would sort of use each of these medicines, and how do you make the choice or the decision on what to use?
I guess I'm thinking largely about 1, patient preference, 2, comorbidities, and then 3, like just like kidney and liver function, mostly kidney function. So if they have concurrent opioid use or opioid use disorder dependence, then naltrexone is pretty much out, and acamprosate might be a better option. But acknowledging that acamprosate is like TID dosing, and then disulfiram kind of sucks for most people. Not to like cast my own feelings about it on there, but it works for some patients, but not tons. I think you have to be in the right type of program and have the right, have certain goals to be able to use that medication, and then trying to figure out, from a medication adherence perspective, is an injectable medication, if there's no opioid use disorder, going to be better? And then we have the magic that is Vivitrol.
Great. So first and foremost, I love that very first comment, which is, what is the patient's preference? Because the medicine that will work the best is the medicine that the patient will ingest. And we do such a good job sometimes of selling people on medicines that they never take. And so you want to make sure that the patient's on board with it. And, exploring what their experience has been and why they're making the judgment that they're making, and or what their preference might be. So that's the first thing. And then the next thing is exactly right. So where are they at in terms of other comorbidities? Can you think of, or can someone tell me, the patient population that does best when or excuse me, the medication that works best for folks who have a family history of alcohol use disorder and strong cravings to drink alcohol?
Naltrexone.
That's right. So that's naltrexone. And the family history is an interesting one, because we often ask about cravings, but actually there's data to support, if someone has a strong family history of alcohol use disorder, that naltrexone might actually be more beneficial to them. And the difference between Vivitrol and oral naltrexone. So how would you make that choice? So Taylor, you said compliance and or ability to take the medication preference. Those are great thoughts. What else might lead you to using one over the other?
Yeah, I know sometimes people who try oral naltrexone have some undesirable side effects, including like a lot of GI upset and nausea. And if they've tolerated the medication before but have had side effects, sometimes they'll tolerate the IM injections much better.
Okay, I like that. What else?
Are they able to follow up somewhere that can keep giving them Vivitrol injections?
Practical. I am loving the practicality, and you'll find this too. I think that is so important to keep this in your mind with these patients is, we can do the best randomized control trials, and like if you're not thinking about just basic stuff of can you actually get to a clinic? Do you have insurance that will pay for the med? Uh, those are so important. The practical. Are you completely terrified of needles and will never agree to an injection? Right? Have you had a bad experience with an injection? And if so, how was the injection given? And can we actually counsel them and see, there are times when people accidentally do not put the medicine far enough in and they'll have, a big hematoma with a injection that they won't have again if it's actually done properly, and you can counsel them on that. Um, what other sort of caveat when you're thinking about naltrexone? Certainly, if somebody has opioid use disorder, you're going to want them primarily on buprenorphine or methadone as primary treatments, and that won't work with naltrexone. But what other differences in terms of patient populations might you select IM naltrexone as opposed to oral naltrexone? So if someone has a history of cirrhosis, um, IM naltrexone does not go through first pass metabolism. And theoretically, oral naltrexone at 50 milligrams actually has never been shown to worsen liver disease and can be used in patients with cirrhosis. But sometimes people are worried, and that extra layer of reassurance can help people who may have a concern. Um, it's also important to just educate people that we do now have evidence that shows that even in cirrhosis, patients who are on a medication, including naltrexone for alcohol use disorder, actually have, if anything, improvements in their liver function over time, as opposed to any negative consequences or side effects from the medication. Okay, so what about a camprosate? So what folks might you think of that are particularly benefited by a camprosate, and where you'd want to choose a camprosate over naltrexone, maybe?
I think people who their goal is abstinence from alcohol, they have been shown to have like better number needed to treat compared to naltrexone. So that would be one demographic.
Wonderful. So that's great. And so that is one piece of information we really do have, which is that naltrexone has great evidence for reducing heavy alcohol use and helping people with cravings. But for whatever reason, a camprosate actually has more evidence for folks who have the goal of complete abstinence and who have been withdrawn from alcohol and are not actively drinking. You can absolutely use a camprosate if somebody's actively drinking, but the best evidence is for those who want to stop drinking completely and have been withdrawn from alcohol. The other folks are obviously those who also may have liver disease or who are on co-occurring opioids for the management of opioid use disorder, or are on a chronic opioid for whatever reason. That's low-hanging fruit for acamprosate. And then what about disulfiram? What patient population and or population of folks would you consider this for, and what patient population would you say, never, this is not a good idea?
I think kind of like Taylor was saying, like people that really want that and feel like that is kind of like going to be a big motivation for them, I think sometimes can do well. Also, people who maybe they aren't like daily drinkers, but they like have situations that they have to go into that they know will be triggering for them. And then you can be like, okay, when you go to your cousin's wedding and it's going to be really hard not to drink around your whole family, like take disulfiram, and then you like know in your head that you like really can't do that. And then I think people that like, obviously, anyone whose goal is not abstinence would be a very bad candidate for disulfiram. And then also anyone who has other like really significant medical comorbidities, because it like if something were to happen and you were to drink, people that are like medically fragile might do badly by like you're making them sick. Yeah.
Yeah. So in my experience, and this is, obviously just my experience, almost everyone that I've prescribed disulfiram to has tried drinking on it at least once, just to give it a go and see what happens. And so if somebody has significant cardiovascular disease, if they have esophageal varices, they're about to explode, we definitely don't want to give that medication to somebody who could really have a bad medical outcome related to it. And then the ones that actually have the best evidence are people who really do have incredibly strong motivation and want the medication. So physicians in health physician assistant programs sometimes want this medication, pilots, professionals, and then just exactly like you said, Laura, the as needed version of it can be really useful for high risk situations. Jim.
Yeah, I tend to think of it when someone has a relationship where there can be like an observing of the taking of the medicine person. And that can be really wonderful in some families and really disastrous in other families. So if it's on the table or if it seems to be bubbling up in the context of their relationship situations, I might mention it. But usually I'll ask them to think really carefully hard how that would be in their family. If someone starts cheeking it and spitting it out, that's really toxic. And if someone has sometimes it's hard to separate out what's a partner trying to help you get sober from a very controlling and difficult person. It can be a fine line. So I really ask them to see if they would feel comfortable. And then we talk to the other person. If the person feels good about it, we bring them into the relationship. So someone once told me it's the I love you pill because theoretically your loved one will watch you take it and then give you a positive reinforcement of affection for having taken it. And in some families, it's been pretty great, although that's a pretty small number. But we have sort of like 2 or 3 at a time in our whole panel for maybe doing that. So
yeah, it's a double-edged sword. It can be really useful and really toxic, and exactly correct. I totally agree that it's really understanding the dynamic and how it may or may not be useful. That's great. Can you give it to patients who have liver disease and cirrhosis?
I think if it's compensated cirrhosis, it's okay.
Jim is a firm no.
It frightens me. I'll just say it frightens me. I'll just say that.
So this is the thing that's weird about disulfiram, right? Is like the actual sort of liver failure that occurs in the hepatotoxicity is idiopathic and not related to whether they have cirrhosis or not, or have liver disease or not. With that said, if someone were to have that and does have cirrhosis, they're probably not in as good a shape to try to work through that if they do have one of these negative reactions. I avoid it for sure. But the interesting thing is there are patients who are like, it's the only medication that has ever worked for me. They have cirrhosis and it's like the difference between them dying and not dying. And actually, it is okay to use it, even though it can cause fulminant liver failure. It's not a complete contraindication. All right. So what two medications have FDA approval which have randomized control evidence for this particular patient without FDA approval? So what other medicines can help with cravings, with protracted withdrawal, with reducing return to use?
I think gabapentin's on the list.
Great. So gabapentin has great evidence for helping those with mild and moderate alcohol withdrawal, reduce benzodiazepine burden, and helps with protracted alcohol withdrawal. So it improves sleep, it helps reduce anxiety, and it can help reduce cravings in those who do have alcohol withdrawal. So if a patient has alcohol withdrawal of any kind and has cravings, gabapentin does have evidence. It's not FDA approved, but absolutely can be used. And in conjunction with naltrexone actually has some benefit over naltrexone or gabapentin alone. So what dose of gabapentin would we be using for these folks?
Is it like higher, like 400 to 600 TID sort of?
So 400 milligrams is the dose 3 times a day that was initially studied for alcohol withdrawal. Anton and Myrek from South Carolina, and then subsequent studies looking at protracted withdrawal or cravings are a little bit higher than that, even 600 milligrams 3 times a day. So usually I'll start 300 3 times a day and then bump up the dose to 600 if they're tolerating the medication to be taken thereafter. Okay, what other, and any adjustments that need to be thought of or made with gabapentin for patients, warning signs or things that you think of being careful with the medication?
Like excessive sleepiness if they have like risky jobs, like a pilot, heavy machinery operator. I think
Yep.
elderly also.
Yep. So sedation, elderly folks, people who have balance problems sometimes. And then you want to renally dose it for people who have a GFR that is less than 50. And then probably avoid it altogether in folks who have a GFR less than 30. The other thing that's really cool about this particular patient, so let's say this person has a history of suicidal ideation and has overdosed on medicines in the past. Can you kill yourself with gabapentin?
I think you'd fall
Actually,
asleep maybe before.
so you actually cannot die from a gabapentin only overdose. And the reason for that is because it requires a protein transporter that gets saturated at somewhere around 3,200 milligrams. So you can't actually get it into your bloodstream. You just poop the rest of it out. So I love this medication for folks who are higher risk with suicidal ideation. What other medications might be
I was
useful
gonna
for
say,
this? Go
for
ahead. Go
folks
ahead.
on methadone, I'm not sure I 100% believe this, but there is some retrospective evidence that might increase the risk of respiratory suppression for folks on concurrent opioids. So it's
Thank
not a
you.
contraindication. We use it all the time, but just be aware there's a debate about it.
Absolutely. No, I actually think this is I'm seeing this more, particularly now that we're seeing higher doses of methadone in the era of fentanyl. These patients who are on like 150 plus of methadone having the potential, and what I've seen in particular is it's the patients who have multiple risk factors for respiratory depression. So, right heart failure, COPD, emphysema, um, and that idea of just getting sedated and pinching off your airway, in addition to the respiratory depression that could be caused by the actual opioid centrally acting, I think does put some people at higher risk. And whether or not that's the actual drug or the sedation or the combination, that would be one area where I'd be a little bit more aware. Although definitely not something I would be like contraindicated. What other medicine might work for this patient? Not FDA approved, but has some evidence for help in reducing cravings and or improving return to use.
Topiramate.
Great. So topiramate is a medication that certainly has evidence in this patient population, can be a little bit anxiolytic. The downside to topiramate is the doses that are effective. Sometimes you just can't get there because the side effect profile is too high. People just get way too sedated. And the evidence is really, folks taking, more than 100 milligrams. So you're looking at like averages of 150 or even up to 300 milligrams of topiramate. So keep that in mind. Some other medications that are used that we won't go into as much. Baclofen can be used. Sometimes patients do well with carbamazepine, sorry, and then Depakote, but those are really outliers. By the time you get to that medication, it's probably not going to be terribly effective. What about the psychosocial interventions for alcohol use disorder? What are the ones that have evidence for helping patients reduce their risk of returning to use?
AA meetings, part of it.
So self-help, right? So AA, rational recovery, self-help groups. Great. What else?
This is more in the like upstream a little bit, but like SBIRT has efficacy and like that single screening.
Yeah, so SBIRT intervention, motivational interviewing, absolutely. Motivational enhancement therapy can be useful to get people into treatment, and continued intervention with motivational techniques is great. And the last one is CBT. So there have been several different models with like contingency management and dialectical behavioral therapy and other things which can be useful, but those are the main three. All right. So treatment of PTSD in the context of alcohol use disorder. What other medications might be useful for a patient who has both of these things? And can you actually do exposure-based treatments for PTSD in a patient who has just stopped drinking? And why or why not? This is an extra credit one that I shamefully put in there for our psychiatry people because it's a hard question. And if you don't know the answer, that's fine. I'll talk about it.
Is there like some efficacy with EMDR? I'd imagine, I don't know the answer, but I imagine it like exposure therapy could be triggering and traumatizing and could lead to return to use for folks if that's not a goal of theirs.
Yeah, so that's the like very reasonable worry, right? Someone is going to go into exposure-based therapies, which that is the gold standard of treatment for PTSD. It's not a medication, it's actually exposure-based treatment, which if you've ever heard of or seen prolonged exposure, you're really asking someone to talk about and literally describe in very gory detail what their worst trauma of their life is, right? And that can trigger people. And so for all the longest period of time, we did not do exposure-based treatments for these patients. And actually, what we found is, yes, the best thing to do is to try to get them to stop drinking, to help them in that vein first before doing exposure-based therapy. But for some people, they just can't get there. And so you can actually do treatments. There are three that are very particular that have good evidence. One is called COPE, the other is called Seeking Safety, and the third is CPT, or Cognitive Processing Therapy with SUD. And the goal here is the first like month of treatment is really all about establishing coping strategies. How do you actually deal with stress? We're not even going to talk about the trauma, but we're going to give you techniques, and a lot of these are actually borrowed from DBT. So, how do you actually get yourself out of a panic attack? By using ice water, exercising really vigorously until you're completely tired, taking a super cold shower, those kinds of things, to give people tools to deal with what absolutely will occur by definition when they start talking about trauma, is their anxiety level will increase. But when these modalities have been used in patients who are drinking and going into PTSD treatment, it actually doesn't result in worsening alcohol use. What ends up happening is you just get very high dropout rates. So, so the other thing is, medication wise, what are the meds that might be useful for a patient like this, um, both for alcohol and their PTSD? So SSRIs, actually, just SSRIs for the treatment of PTSD, anxiety, and depression. So those three categories of patients, if they have co-occurring disorders and you treat their underlying disorder, they do better not just with their underlying disorder, but also with their alcohol use. So there have been studies looking at the differences between treating somebody with naltrexone alone or naltrexone plus sertraline, if they have anxiety or depression, and they do better in both metrics. So we sometimes are hesitant to add antidepressants in patients because it's like, oh, is this a substance-induced mood disorder or anxiety disorder? And the truth of the matter is, if they do meet criteria for depression, if they do meet criteria for PTSD or anxiety, they should be put on an SSRI, and it's safe to do that in patients with alcohol, and they do better. What medicine is best? No one knows. Sertraline has the most evidence, but citalopram, escitalopram, totally fine. Um, uh, SNRIs don't have as much evidence for the co-occurring patients, but there are some folks who with PTSD who do well with SNRIs. All right. Any questions before we move on? All right. So we're going to talk about opioids next. Yeah, go ahead, Taylor.
Oh, I was just, I know there was, I know this is everyone's least favorite and favorite thing to talk about, but there was like an RCT with GLP-1s and alcohol use disorder earlier this year. I know they're hard to access, and I just wondering if that's something that you've tried to use or integrated for for a certain population or.
Yeah, I love that question. So, at the VA, GLP-1s are actually contraindicated if you have an alcohol use disorder, which is, I know. They won't approve them. And it's because GLP-1s right now only have approval for weight loss. I think these things are going to be wildly successful. When you're seeing the medications roll out in populations who have both disorders, people are doing better from alcohol standpoint. Um, and actually, I was on a call about patients who are experiencing obesity in the VA are often denied gastric bypass if they have an ongoing alcohol problem, and they don't have access to GLPs because we say that they can't. And so what we're really trying to do from a leadership standpoint is say, okay, well, these patients are in this sort of donut hole here. Well, why don't we actually say we're giving this to the patient for weight loss, we're not giving it to them for alcohol, but let's see if it helps. And so there's going to be more data. There's a lot of folks who are writing up grants right now to specifically look at this in VA. But I really am a huge proponent in folks who have obesity for both of these things, because the truth is actually um, gastric bypass puts people at higher risk for complications related to alcohol. And it's not a great intervention for folks who have really severe alcohol problems, because they do end up with really, I've seen really bad outcomes with folks who have had gastric bypass, and actually at times not even had a severe alcohol use disorder in the past and then develop a terrible one, Wernicke's disease, all sorts of complications. So I'm a firm believer we should be studying it more and trying. And I'm hopeful.
Yeah,
Jim, do you
we're at
want
the
to
same
comment?
spot in
Yeah.
Swedish. Yeah, we're roughly the same spot. We haven't been prescribing out of our clinic, mostly because we don't think we're smart enough to get it approved through insurance. I have occasionally called somebody's primary care provider and say, "Hey, if there's a way to get this through for pre-diabetes or something like that, I think it'd be really helpful." But there as of yet, there's this RCT may change things, but there's no indication, which means no insurance coverage specifically for the substance use disorder, and we rely on the co-diagnosis. I'm looking forward to a time when our providers in our clinic will prescribe it for someone who is overweight if we can get it through. But I think honestly, we just haven't been smart enough to figure out the insurance approval process. It'll probably be after you finish fellowship before it is FDA approved for substance disorder. But I'm expecting that will probably happen at some point, honestly.
I mean, that just again, in my experience talking to patients who are on these medications, even if they don't have a problem drinking, they'll say like, I drink a glass of wine and then I'm just like, this isn't even working or helping me or making me feel good, which is really promising. Any other questions about that before we move on to opioids? All right. So Monica's a 34-year-old woman with a long history of major depression and severe opioid use disorder, presenting with endocarditis. Medicine team calls for consult, recommendations to treat fentanyl and pain. She has co-occurring chronic low back pain with a long history of spinal fusion related to a car crash 12 years ago. So what are the 3 medications that we can use for management of opioid withdrawal in this setting? Or 3 kinds of approaches, kinds of treatments?
You said specifically for the management of opioid withdrawal.
The withdrawal. Yeah. So what can we do for this patient right now? She's in withdrawal. She feels terrible. She's got co-occurring pain.
So like partial agonist, full agonist, whether short acting or long acting, and then in addition to that, like adjunctive therapies.
Yeah. So methadone, right, is very good intervention for patients who have withdrawal. Buprenorphine, if a person is in enough withdrawal not to precipitate withdrawal. Short-acting opioids, if a patient is sort of unsure about what they want to do and you're just trying to sort of make an intervention and they're worried about, methadone or something like that. And then if somebody is just dead set on, I do not want to be on an opioid medication, you can do symptomatic management, use of clonidine, benzodiazepines, methocarbamol, et cetera, for opioid withdrawal. I have not seen terribly good success rates in those situations, so it's really kind of the last option, and also not something to forget when someone is getting buprenorphine initiated. You can use those adjuvant medications should they have any sort of breakthrough symptoms or concerning symptoms when they're making the transition onto buprenorphine. So how do you make the decision? What do you do? So what would lead you to say patient should be on methadone? We like methadone for this person.
You ask them what they want.
Yeah. Okay. Right back to the mantra of what does the patient want, right? What is their experience with the medication? What are their questions? Have they had success with something over another? And just exploring that. What they want is absolutely the first question and the most important question. And also just really making sure that you know what their experiences are, because so often I hear I will not take buprenorphine. I will not take Suboxone. It causes withdrawal symptoms. and they just took it too early and precipitated withdrawal in themselves and just don't have a great understanding of why that happened and how it worked. Okay, what else might lead you to treat a patient with methadone instead of buprenorphine? Does the pain situation here compel you to move toward methadone? Yes or no?
I don't think it would for me. I think if the patient wanted to be on buprenorphine, then we would be able to work with the acute pain and just knowing that she might need more, like picking a higher affinity acute pain treatment like hydromorphone or something. But I think there's workarounds if that's her goal.
Wonderful. I love it. So there is a misnomer that buprenorphine shouldn't be used in patients who have chronic pain and or the patients with chronic pain do better on methadone. And the truth of the matter is actually when you get methadone in a methadone clinic, the best they can do is split dosing. And they can't do split dosing for the indication of pain. The only indication for split dosing is if people are rapid metabolizers of the medication. So once daily methadone actually doesn't do a terribly good job at managing pain beyond about 6 or 8 hours. It's a fantastic medication to prevent withdrawal symptoms and prevent cravings for 24 hours, but the actual pain effects don't last that long. So in some ways, buprenorphine can actually be even more helpful for some patients because they can actually split it as frequently as they want. And they can take the medicine 3 or 4 times a day and get pain relief from that. And just as you said, Laura, it is not a contraindication to use full mu opioid agonists. And people can have really good pain relief while on buprenorphine who have acute and chronic pain conditions when they have breakthrough pain. And just like you said, you want to just be aware that using a higher affinity medicine is probably going to give you better results. If you give 5 of oxy, it's probably not going to do the same thing as if you give a dose of IV Dilaudid. And in these situations, when people have a really significant amount of acute pain, who come into the hospital already on buprenorphine, I like to keep them on the medication and then use PCAs to adjunct pain treatment. It gives people a better sense of control. It's a little bit more work on the nursing side of things, but in my experience, it has gone much better. Jim, I don't know if you have thoughts on that in
Absolutely,
particular.
I get to lecture to this to the ACAM folks. The evidence is fabulously clear. It's all retrospective evidence, but when you stop the bupe, it's always worse. Their meds are more, not less. Their pain is worse, not better. So if you ever get involved, if someone's on bupe and they're having a surgery, however bad it is, stopping the bupe is never going to help the patient. It's always going to make it worse. So for the acute sort of perioperative pain. I was going to say, John, the chronic pain is so weird. And I talk about chronic pain, not her endocarditis pain. Maybe she's going to get a valve replaced, but like her chronic back pain is so weird that actually even Vivitrol, naltrexone, which I don't use for opioid disorder because it doesn't avoid overdose, but there's not evidence that people have worse pain on Vivitrol compared to people on buprenorphine, because chronic pain and the opiates are weird and weirder
Yes.
than you think they are. So don't worry too much about great opioid management for chronic pain, because whatever you do, you're kind of going 2 directions at once and you never get anywhere no matter what you do. So in the end, what the patient wants to do, I think what Taylor says is true. I got to be honest though, we've had a bunch of people in the pregnant women's world where we very carefully micro-induced their buprenorphine with no precipitated withdrawal, and 5 days later they still felt awful and asked to move over to methadone. And I think if they could have lasted a month, that might have worked out. But I think when I hear people tell me they're using like 2-3 grams of fentanyl a day, I'll do whatever they want to do, Taylor. I swear to God. But if it was up to me, I would just go with the methadone, because I do think that just to get the withdrawal relieved with the partial agonist with its built-in ceiling is hard for people who are going hard on fentanyl.
Yeah. So thank you so much for those comments, Jim. And so Jim and I are on this work group called Bridge for the Washington Healthcare Authority, where it's this group of expert people who are coming together to create these algorithms, and we're all kind of looking at each other and doing the best that we can, but there just isn't really great information as to what is the ideal medication. And I tend to agree with Jim, and just in terms of, historically with heroin, buprenorphine, you put them on that after they're in withdrawal, it helps immediately. They feel great. Everything is fine. But the difference in how stimulated people feel on fentanyl and how they feel on buprenorphine, that delta is sometimes just incredibly hard for people to tolerate. And so I really try to also educate people, like, here's the thing. Even if we don't quote unquote precipitate withdrawal, meaning that the medication is actually causing a removal of fentanyl from opioid receptors and a precipitation of withdrawal and a cow score that increases more than 5, they're still not going to feel like they feel when they're taking fentanyl. They just won't. It's not the same medicine. It's not going to do the same thing. And their expectation really shouldn't be that they're going to feel the same way. And if they can make it a month, it's exactly right. There's this thing that happens with opioid receptor resetting for whatever reason, that people feel better, but those weeks in the transition period can be rough. They can be really, really rough for folks. But it's also a double-edged sword with methadone, because getting people on a good dose of methadone that's really helpful for them can take some time. And even when we're doing now rapid inductions and getting people onto higher doses of methadone in the hospital, um, there are some folks who just need higher doses that take longer. You can't get somebody to 150 of methadone in 3 days. It's just not.
Yes, you can. Yes, you can in the
you you
hospital.
you tell
In the
you t-
hospital.
Yeah, well, yes, okay, fair enough, and we'll hear about this later on in the year, because you are far more courageous than the rest of
Yeah.
us over at Swedish. But this is I think a really good example of, we're doing the best we can and trying different things. And the idea of going to 150 of methadone in the hospital in a week, 5 years ago, you'd have gotten sued for malpractice. But now we actually see people with this super high tolerance. And I have done the same thing. I have a patient who comes in and he's like, I need 160 of methadone, and he tolerates it immediately. It's remarkable. Anyway,
But I'll just say you got to be smart. You got to divide your doses. You got to check a lot. You got to have nurses that you can keep watch on things. But the other thing to remember is you don't have to start methadone fast if you give enough short-acting opioids. So for this patient, for example, maybe she's in terrible pain. Maybe she's going to the OR tomorrow morning for a new valve. If she blew out a valve, you can always get someone out of withdrawal with enough opioid. And it might be a lot, and people might be weird about it. But if you give enough oxycodone, hydromorphone, morphine, whatever you want to use, if you give enough, you'll be okay.
yeah, I like that. My particular practice with these folks, if I'm going to do methadone, is using methadone as sort of a basal, and then having the smaller or shorter acting as the pain control, and really trying to counsel teams when you're in the consult setting, like, the methadone is not for pain. This is for opioid debt and helping with withdrawal. And we still need to do the other medications. And the morphine equivalents, when you start adding it up for some of these patients who are taking grams of fentanyl, particularly those who have used it for a long period of time and are smoking 10, 12 times a day, it's remarkable what their tolerance is. Really remarkable. So,
And one last thing I'll say is, as you guys are rounding, something very special you'll do if you tell a patient that you shouldn't have to be in withdrawal. You deserve to have your withdrawal treated. I'm going to try my best. I may not be perfect, but this is something we think is something we owe you. The mere fact that you're trying will make people feel so much better, and that you validate that they're not supposed to be in withdrawal, because they don't hear that from most people in the team. And the fact that you think it's important and you're making an effort, that's alone going to make people feel better.
absolutely. Yeah. People in opioid withdrawal feel like absolute shit. And if you can reassure them that you're going to help in the best way that you can is great. Okay. So other considerations. So what might make you lean toward buprenorphine instead of methadone for the treatment in this particular patient? Think about the logistic stuff too. Anybody ever practiced outside the city of Seattle and or a large metropolitan area?
If she's coming from a rural area, you want, or just anywhere that you don't know the system, you want to know what methadone programs would be available to her. And sometimes people, I think now that it has changed a lot. I think historically it was also hard to get bupe if you had to like go to find also a provider in your area that was comfortable doing that, but that is getting better. And so in general, it's easier to get uh definitely sublingual bupe and increasingly LAI bupe kind of in the community as opposed to driving somewhere to go to an OTP if there isn't one close to you. And then also for her, she sounds like from the stem, she's currently in a lot of withdrawal, and so you could get her onto bupe relatively quickly, theoretically.
Yeah, so the advantage of buprenorphine is that you can get to a protective dose of buprenorphine overnight with a patient who has significant opioid withdrawal with larger dose initiations. And just exactly correct. So there's really good studies looking at distance to opioid treatment, and that includes time. So it doesn't have to be just how many miles away, but how many buses do you have to take, et cetera. So the longer it takes you to get to a methadone program, the less likely you're going to do well. And we have 54 counties in Washington State, and we have less than half of them with an OTP. And so the access to methadone care is incredibly limiting in this country, and that's definitely something you just have to think of logistically with a patient. Asking somebody to go to a methadone clinic, that is going to take them 2.5 hours to get to, is going to be a lot more barrier for the patient, particularly now with telehealth laws. So in Washington State, for instance, you can actually do buprenorphine prescribing via telehealth. And if you see a person even one time, you can do a continued buprenorphine dosing from there on out. So there's just the access to care issues is something to consider.
When I
Okay.
see someone who's like on dialysis or in a wheelchair, I always kind of want them to be on bupe just to make their life easier. But I do find that they almost universally respond to what their body needs, not what works. So sometimes people are like, they're going to dialysis or going to methadone. The other solution to the problem Jonathan talked about is what you guys will do, maybe not in the next 3 months, but over the next 13 years, more OTP, more transportation, more support, and maybe even methadone prescribing, which has been floated in Congress a few times. So over the next decade, guarantee things will become easier for people, and you guys will be part of the world making that happen.
Absolutely. There's a proposal right now that methadone be available in FQHCs, which would be a giant win just in terms of opening access to care, because federally qualified health centers all do have some similar funding. The access to methadone could improve significantly. And again, just as a reminder, methadone is a Schedule II medicine, so you can only get it in an opioid treatment program. And why is that? Is methadone not safe to prescribe in a clinic setting?
Stigma and historical regulations.
It is 100% the theoretical idea that of diversion and preventing diversion. It is methadone has never been shown to be dangerous if prescribed in clinics. and you have to look to, other countries because we don't have that here. But this is not a safety issue. This is not related to safety. It's related to theoretical concern of diversion of the medication. So just keep that in mind. Okay. So if you were to start this patient on bup, what dose would you start them on, and how would you do it? There is not a right answer. There's a wrong answer. Don't give them tiny little doses if they're in full mu-opioid withdrawal.
Like something between 10 to 12 milligram, we can start it.
So historically, we've done 2 to 4 milligrams to start. This is not what we want to do anymore. Usually what you will want to do is give up to 32 milligrams in the first day. How you do that has not been really evidence-based or shown in any particular way. I personally do 16 milligram dose and then follow it up with another 16 milligram dose. I know Harborview, they do 8 milligrams and then do another cow score an hour later and do 8 and 8 and 8. What do you all do at Swedish, Jim? I think he jumped off. And anybody know at Swedish? Anybody have any other experiences of dosing? Okay, that's fine. What dose would you give of methadone initially for this patient?
I guess I don't know the protocols of wherever she's at that would hinder it, but she could definitely tolerate like 40, 50 plus additional dose at, after a peak check.
Yeah, so
rapid.
So we used to say 30 milligrams, and now 40 milligrams is pretty routine. And usually, again, depending on the system that you're in, doing a 40 milligram dose and then doing cow scoring, and if there's still withdrawal symptoms, giving additional doses is usually okay. The main thing that you just want to be aware of is that methadone can stack. It's a long-acting medication. So if you do give higher doses, you want to make sure that you're monitoring the patient, that they're getting regular vital sign checks, that the nurse is really taking a good look at them and making sure that they're not experiencing any kind of respiratory problems. And the truth of the matter is, you see sedation and somnolence a hell of a lot sooner than you'll see respiratory depression. And so when a patient is writhing around in bed and you've given them 40 milligrams of methadone and they say they still feel like they're in withdrawal, it is okay to give as needed methadone beyond that. Jim, at Swedish, you're doing heroic doses. So how are you protocolizing and what do you do?
It's not always the same for everybody, but I would say it's based on repeated doses. So if I remember that methadone will peak at around 4 hours for most people. If 4 hours have gone by and they're still in withdrawal, I'm going to give more. So I will sometimes give doses every 4 hours. We might do something as simple as 10Q4 PRN, but we might do something fancy. If I really think someone needs 120, but I'm scared to give 120, I might give 30, and 4 hours later give another 30, and 4 hours later give another 30, 4 hours later give another 30. And now I've given 120, but I've checked every 4 hours. Yeah. If I want to give another dose at less than 4 hours, I have to be really sure it's not too much. So if I know that it's not too much based on some piece of evidence, their history with methadone, we knew them from last week or whatever, I might give it less than every 4 hours. But frequent and repeated dosing is kind of the key to rapid escalation. And then you just got to kind of keep it in mind. We've been going pretty hard, and you'll see what we do over the course of the year. We're not getting anybody Narcan. I promise you that. We're not intubating anybody. I would say, though, that sedation has become problematic because in a world where most people use stimulants, when they come to the hospital, they have stimulant withdrawal, which is sleepy, and they appear sedated even when they're in opiate withdrawal. So holding for sedation can really get in your way. So we've switched to mostly holding just for rest rate less than 12, which is very confusing. And very frustratingly, even dosing by cow score has been kind of problematic. So when I shift to patient complaint of opioid withdrawal, which is a very soft thing.
Mm-hmm.
To use PRN methadone in the hospital setting implies a lot of culture building with your
Yeah.
nurses and with your patient, actually.
Yeah.
And you will become so expert at this about shaping a unit, and you will see the huge impact a fellow rounding can have on the patient and on the nurse. As simple as thanking the patient for asking for their PRN methadone can have a huge positive impact on the whole milieu, and thanking the nurse for giving it.
Great. All right, I like it. And it is, I think, just a really important thing to remember about methadone, in, comparatively to something like fentanyl, where you're going to get peaks and valleys with fentanyl that are pretty rapid, and a lot quicker. And with methadone, it sort of hits people, at a slug, somewhere between that 3 to 4 hour mark. And so it is useful to know when the doses occurred, and to time your evaluation of the patient when it is peaking, because you're going to see the worst of the sort of side effects or problems that may occur in that time frame. Okay.
We actually give our morning dose of methadone at 6:30 a.m. so that when we're rounding at 9 or 10, they're already peaking. So it makes our job very easy.
100%. We do the exact same thing. You want to make sure that first dose in the morning is around 6 o'clock, so that your rounding gets to see them at their peak. Yeah, great. Okay, so I'm actually skipping that. Okay, we're going to talk about Alex, who's 16, presents at the behest of his parents due to worries that he's a pothead. Before we move on to that, any questions? We reviewed sort of general principles of opioid. Any particular questions about methadone or buprenorphine? We didn't talk about straight to long-acting injectable, which I think it will definitely be something that you'll see this year, and we're trying, and I think will actually have some potential real benefits for folks. But are there any questions before we move on to cannabis? All of you will become completely facile with treating opioid use disorder through when you're done with your fellowship. Like it's one of these things that is intimidating at first, and you do this a number of times, and you get reps under your belt, and it's really magical to help people who have had an incredibly difficult time navigating health systems, who have completely different opinions of how they interact with healthcare now that we're really more present on inpatient services, and helping our colleagues with not as much addiction experience. So. All right, so we got a 16-year-old presents for worries that he's a pothead. He's not been himself for months now, and they're worried that drugs are ruining his life. He was a good student in the past, but never really liked going to school. We're now getting reports that he's skipping school, and we found weed in his room and a pipe. How do you evaluate if he has a substance use disorder? Or is he a typical 16-year-old kid who likes to smoke weed? Is there a difference? So practically speaking, how do you navigate the family situation?
So I'll chime in a little bit on this one. So I think first of all, you want to set up a visit where you get some time alone to talk with Alex away from his parents, and give an impression that you're here to sort of hear him out, hear where he's at, and have an honest discussion. And, somewhere in there, you'll mix in some of the DSM-5 criteria for a substance use disorder. Like, you're going to ask about withdrawal, you're going to ask about tolerance, you're going to ask, how he obtains cannabis and how much effort he has to go through to do that, if he's spending any money to do that, how he feels it's affected his life, and how negatively it's affected his life, sort of all the things in terms of that. So yeah, I think also from a psychiatric perspective, while he's a little bit under the age, I'd sort of ask about psychotic symptoms and just make sure that there isn't like a primary thought disorder that is starting to brew, but he's a little bit on the young side for something like that. It might just be in my mind though. That's generally where I'd start with a guy like this.
Yeah, so heavy cannabis use absolutely can be associated with development of psychosis, and so that is something to definitely keep in mind in a patient like this, particularly if they're sort of withdrawing. That could be a substance use disorder, but it also could be an emergence of a psychotic disorder. Manic episodes are also something more prevalently seen in higher dose cannabis use. This doesn't seem like the clinical picture for that right now. And then the other thing is it's super important to be able to establish rapport with Alex and also recognize that this is a family that's worried, and that's good. Right? And like parents who are engaged and worried and are trying is fantastic. And so um threading that needle of being able to engage with Alex and be able to develop rapport with him individually, but also family systems are actually really helpful when they are intact and when they're pushing in the right direction for kids. And I think sometimes our initial sort of reaction is like we just want to make sure that we just establish rapport with the kid, but parents can be really useful. What other kinds of things do you worry about in terms of co-occurring disorders when someone's using cannabis, especially a teenager?
Like recently, I have seen a patient of cannabis use disorder who is now also having ADHD, depression, and anxiety. They were the
Yes,
co-occurring disorders.
the trifecta: ADHD, anxiety, depression. So yeah, so it's incredibly common for kids to use these substances when they have anxiety, when they have ADHD, when they have depression. And um, when kids are using cannabis, they are at higher risk for suicidal ideation and suicide attempts. And so it is important to just recognize that you want to be screening for mental health disorders in these folks. And then what can we do to help him? What kind of treatment approaches are available? This is the second portion of this. Sorry, I'm skipping ahead because I'm recognizing we're getting low on time. You can read this stem and then we'll talk about the next part. So what do you think about with this kid? What are some of the likely um, uh, things that are going on with him?
It seems like he probably is experiencing a lot of uh good reasons that he's like feeling the need to smoke pot. He's got depression, he's having trouble socially in a new school, not feeling supported, not having other outlets.
Yeah. And the this is intended to be tough, but um does this kid meet criteria for a major depressive episode?
Don't you have to be free from any substance use before diagnosing?
Yeah, so according to the DSM, if you're using substances, you can't technically say this is, only a major depressive episode. With that said, the thing that is a little bit more worrisome is when someone does start having suicidal thinking and or they're so dysphoric that they're not enjoying something. And that is a little bit more worrisome than sort of the typical things that could be associated with, trouble fitting into a new school, anxiety problems, etc. How might you be able to actually delineate the difference between a substance-induced disorder and an underlying depressive disorder if someone's actively using?
Get kind of a timeline, like ask about presence of anxiety or depressive or mood symptoms prior to use of substance, or if there were any present during times in which substance was not being used.
Yeah, exactly. So it did, which came first, right? Did the symptoms of depression actually come before the heavy cannabis use? And if that happens, it's actually pretty reasonable diagnosis to be able to make for a kid. And the other thing to recognize too is that psychotherapy can be really useful. And some people are worried about putting kids on medication, but actually serotonin medications or SSRIs can be used in this patient population and not actually require lifelong treatment. And you can use medications in these situations while you actually continue to help them with whatever other issues are going on. So anybody seen the movie mid 90s? It's a movie that came out about 10 years ago. It's a like kind of coming of age story, and there's many like this, but I think making sure that when you do interface with kids, and some of you won't, but a lot of you will, that you do recognize it's complicated. There's a lot of ins and outs and what have yous going on, hormonal changes. uh, I think being in junior high and high school is in itself a depressive risk factor, especially new kids who are having difficulty fitting in. Um, so um, this kid actually was diagnosed. He did have depression. We did start sertraline for him, and he actually started doing CBT to manage anxiety and depression. And he felt a little better, but still could not sleep without cannabis. And he says he feels better when he's high and can't understand why it's such a big deal. He also, the only friends that he has are smoking cannabis, and so when he's hanging out with them, he's like, "What am I supposed to say? I don't want to use this." So what kinds of things could you do for this kid to help? How would you address it, and how do you help him move forward? So first off, how do you respond to this?
You got to give them an effing break. That's the
Yeah,
main thing.
yeah,
I try to think, I'm not very good at adolescent care, to be honest, but I tend to think from a contingency reinforcement approach. Like, what are the things that goals that he might have and things that can move that goals, setting up parameters where there'd be reasons not to use marijuana. And that might be things that he loves to do, or it might be things that his parents are engaged in. But rather than get into like being mad at him for using, to try to create some positive reinforcements around moments of non-using as much as possible.
I love it. And I think, the recognition that you are trying to help the kid move forward, and cannabis is clearly a problem. But also at the same time, the recognition that he's in a tough situation. What about the insomnia? Um, how would you talk about that, and or is there anything we can do for that for him? It's a common withdrawal symptom. Actually, people will have anxiety and insomnia are two really difficult ones when people are actually developing tolerance and dependence on cannabis. Any medications that actually can be useful?
I mean, I don't know about the pediatric world, but gabapentin is always one that we turn to, not for insomnia necessarily, but in like withdrawal management, and it could help with the insomnia.
Mm-hmm.
Or hydroxyzine also.
Mm-hmm. Sure. So anxiety management medications. Anybody heard of N-acetylcysteine for cannabis use in kids? This is a very low barrier medication that may actually help with some withdrawal symptoms and help kids feel better in regard to cannabis withdrawal. Mirtazapine is a medication that does help with anxiety and depression, can be used and also fairly sedating. So that is something that is theoretically a medication. The other thing is actually just the basics of good sleep hygiene, which is really tough for kids because, they're in this phase of life where they're sleeping a ton. They have to get up earlier than they want to get up, and just the mere act of getting up the same time every day is one intervention that can be just concrete and easy, that can help with insomnia regardless of whether or not the kid is actively using cannabis. Okay, what questions do you have about anything before we end? Anybody know this movie? One of Val Kilmer's widely under-recognized movies that I thoroughly enjoy. Yeah, obscure. It's called The Sultan Sea, and it's an indie film, but an interesting one. So you're going to hear about stimulants still, and then also about tobacco. In the coming weeks. I'm going to send out lots of links and emails in the coming 2 days here. So I owe you the cannabis lecture, the alcohol lecture, and then all of the Swedish folks, the previous resources, and then the link to the YouTube channel. And I'm going to make it private just so that because these are recorded and we're all sort of talking. So with the link, you'll have a little passcode to enter. Cool. Have a great afternoon, and good to see the Swedish folks. Good to see Elena down in Pierce County. It's Puyallup, is it? It's yeah.
Yep.
Awesome. Yep. Very good.
So I'll say we're not going to do the 4 to 5 thing today, so we are literally done for today. The YouTube videos are going to be wonderful. Jonathan, thank you so much for recording them and making them available to our fellows. It's a really, really big deal. Abby and I are scrambling, but hopefully next week we'll have some content between 4 and 5. So we'll see about that. Okay.
All right, everyone else, see you later. Have a good afternoon.
Take care.